welcome you all once again to yet another webinar, a 22nd one in the series. And thank you very much for your inputs. And we have tried to incorporate your suggestions. Most of you have expressed the desire that your Q&A to be discussed. And we will try our best to discuss, but you understand that due to lack of the time, many times our speakers do answer the questions, and some of which are meant for discussion would be taken up towards the end. As usual, you will receive an email after the webinar to give us your feedback. And once we receive the feedback and completion certificate, we will send you the email with the CME credit certificate, email it to you. And these webinars, as well as all the past archives, are available on our IUSG website to all the non-members as well. So you can log in anytime if you have missed out on any one of them, or if you want to revise or relook at any one of them. Thank you very much. And with this, I will pass on to Rima. John and Rima are now the members from our education committee who will be there in all the webinars and gradually, take over and be there for you guys. So Rima is going to be moderating the session with us. Over to you, Rima.
Thank you, ma'am. So I would like Mark to introduce the webinar and the speakers, and then we take over for the subsequent talks. Mark, please.
Okay, so it's a great pleasure to welcome everybody to this 22nd webinar series, and we're going to talk today about acute retinal necrosis, and we have a great panel of speakers. We'll have Yolanda de Groot, and that will be talking about the pathogenesis. And then several other speakers will talk about the clinical manifestations, the therapy that is required, and we'll also talk about the management of these patients, both medically and surgically. So I think we should get started, and then at the very end, we can have a discussion about the best approach to these very complicated cases. Rima, back to you.
Thank you, Mark. So it's a pleasure once again. So over to you, Yolanda de Groot, who will be talking on pathogenetic mechanisms of viral retinal necrosis.
Thank you, Rima, and Mark and Vishali for inviting me. Yes, first, I have no conflict of interest to declare. So viral retinal necrosis is caused by roughly three viruses: herpes simplex virus types 1 and 2, and varicella zoster virus. And it comes in, 2 or 3 clinical manifestations. The acute retinal necrosis, which can be unilateral but also bilateral, and is mostly seen in immunocompetent hosts, and is caused by HSV 1, 2, and VZV. And there is the progressive outer retinal necrosis, which is manifest in severely immunocompromised patients with a CD4 count below 50 cells per microliter, and is mainly caused by varicella zoster virus. Now, acute retinal necrosis was first described in 1971 by Urayama and co-workers, and it was referred to as Kurosawa's uveitis. Then in 1978, Young and Bird described a bilateral form, and they called it BARN, so bilateral ARN. And then in 1982, Culbertson and Blumenkranz detected herpes virus in the retina, and at that point, it became clear that herpes viruses were the causative agents of the acute retinal necrosis. ARN is a rare disease. It is estimated it occurs in approximately 1.2% of uveitis cases in tertiary centers, and 2 studies in the UK estimated the incidence to 1 case per 1.6 to 2 million per year. The disease can start at any age. But patients with HSV-related ARN are generally younger than those with VZV ARN. And they are usually reactivations from earlier HSV or VZV infections, although viral retinal necrosis can occur during primary infection, often in neonates. In 1994, Gary Holland and the Executive Committee of the American Uveitis Society published diagnostic criteria for ARN. And these were later updated by Takasi in 2015 and also by the Sun Work Group in 2021. But the most important features, particularly during first presentations, are foci of retinal necrosis in the peripheral retina and a rapid progression. And this is shown nicely in these fundus photographs of the Takase paper, where at initial presentations there are these foci in the peripheral retina, and within 2 days they have spread significantly further. So this shows the rapid progression. Now, the pathogenesis of ARN is initially largely due to the lytical viral infection. The virus infects a retinal epithelium and can spread fast throughout, but is then followed by further tissue damage due to inflammatory responses, mainly cellular immune responses like CTLs, but also TH1, CD4 T cells and pro-inflammatory cytokines. But the true devastating properties of the viruses become clear in progressive outer retinal necrosis, which is also a rapid progressive retinitis, but with minimal intraocular inflammation. So this gives to show that the virus alone can cause extensive retinal necrosis. Now, HSV and VZV are members of the family of the Herpesviridae. This is a colored EM picture of a herpes virus. They are large envelope double-stranded DNA viruses of human and animals. And HSV and VZV belong to the subfamily of alpha herpes viruses, and these are all neurotropic. Herpes viruses have many accessory genes, and these make them masters of immune evasions, and this enables them to establish a lifelong latency in their host. They are also considered old viruses, and there are studies where they show that the virus co-evolved with the host, and they're considered one of the most successful virus families. HSV is transmitted upon intimate contact with a person who has HSV lesions. Upon transmission, the mucosa are infected. For HSV1, these are usually the orolabial and conjunctival mucosa. And for HSV2, this is generally the genital mucosa. However, this distribution is not strict. Vice versa, infections can occur. Following the infection of the epithelial cells, the virus infects the nerve endings of sensory neurons, and from there the virus transports to the neuron cell body by retrograde transport. There, the genome enters the nucleus of the neuron and establishes a latent infection. And the genome is present in an episomal manner, so it's not integrated in the host genome. There is no protein expression in case of HSV. And upon orolabial or conjunctival infection, the virus establishes latency in the trigeminal ganglia, shown here. Upon genital infection, the sacral ganglia are infected. Immune surveillance, mostly by T cells and also a little by antibodies and interferon gamma, maintains latency and prevents the virus from reactivating. However, if this immune surveillance is lost, reactivation occurs, and by anterograde transport, so the other way around, the virus transports back to the primary site of infection and will infect epithelial cells again. In case of the trigeminal ganglia, this will lead to, for instance, herpes labialis if the second and the third branch of the trigeminal ganglia are infected. And it leads to herpes keratitis and herpetic anterior uveitis if the ophthalmic branch is affected. In sacral ganglia, it'll lead to herpes genitalis. Other clinical presentations are herpes gladiatorum, which is infection of the skin, and also ARN. VZV transmission and infection is slightly different. VZV is transmitted also by direct contact with chickenpox or zoster lesions, but also by respiratory secretions. Subsequently, infections of the tonsils, upper respiratory tract, and conjunctiva will occur. And within these structures, T cells are infected with VZV, and these cause a viremia. So the viremia is T cell associated, and the virus will spread throughout the body. These T cells home to the skin, but they will also cause infection of the spleen and the liver. And in these organs, further amplification of the virus will occur, and a second viremia will be established, and which again leads to skin homing. And that way, VZV spreads throughout the body, which is obviously different than the situation in HSV. Then, after 14 days, chickenpox lesions will occur, and these coincide with the occurrence of the adaptive immune response. Following infection of the epithelial cells in the skin, VZV also infects sensory neurons, which are usually of the dorsal root ganglia. And by retrograde transport, VZV goes to the cell body and infects the nucleus. And as latency is established. However, the infected T cells are also able to transmit the virus to the neural cells, and also through that means latency can be induced. Like HSV, VZV is maintained episomally in the nucleus, and in this case, only little protein expression is seen, but only in internuclear, as is shown here. And also in VZV, immune surveillance maintains latency and prevents the virus from causing reactivation disease. However, upon reactivation, the virus moves anterogradely along in the axon. It manifests in the skin again and causes shingles or zoster. And shingles is restricted to a single dermatoma upon reactivation. VZV can also reactivate from other ganglia, for instance, the trigeminal ganglia, but also from neurons of the enteric nervous system. And reactivation from other sites can cause enteric disease, herpes zoster ophthalmicus, keratitis, and ARN. So the question is, how do VZV and HSV reach the posterior eye to cause ARN? I think one very likely explanation is that it is a reactivation via the optic nerve, shown here. But there are no obvious links to a skin or mucosa for the optic nerve. There are obviously for the trigeminal ganglia, but also the olfactory system is directly linked to the to mucosa, but the optic nerve isn't. So that would suggest that CNS, central nervous system penetration, is required for ARN to manifest. Now we know already. I have told you that HSV and VZV are transported along axons in anterograde and retrograde manners, so they can go either way. But these viruses can also cross synapses, shown here. which means that they can infect higher order neurons. And by this means, they can access the central nervous system and cause central nervous system diseases as encephalitis and meningitis. And that may also be the way they cause ARN. Now, there are some clues. For instance, in HSV and VZV, several reports have demonstrated that ARN is preceded by encephalitis or meningitis or optic neuritis, indicating that the virus was already in the central nervous system. And there's also a clue from the von Zille reaction. This is a reaction where patients with scleritis, keratitis, herpes zoster, and or anterior uveitis develop retinal necrosis in the contralateral eye. This reaction is named after the von Zille mouse model, and in that model, it was demonstrated that the virus crosses the optic chiasma, which also requires deeper penetration of the central nervous system to reach the contralateral eye. So retinal necrosis development requires deep central nervous system penetration of the viruses. However, by which routes this occurs is still unknown. And with this open question, I would like to thank you for your attention.
Yeah, thank you, Yolanda. So that was excellent. In details, you covered all the pathogenetic mechanisms of the HSV and VZV. So with this, since we take up the questions in the end, we now move on to the second talk. This is a pre-recorded talk by Dr. Jyotirmay Biswas, who will be talking on histopathology and molecular biologic study of viral retinitis.
At the outset, I'd like to thank International Uveitis Study Group for giving me this opportunity to talk on histopathology and molecular biologic study of viral retinitis. I'll be talking on acute retinal necrosis, cytomegalovirus retinitis, progressive outer retinal necrosis, chikungunya retinitis, dengue retinitis, West Nile virus retinitis, histopathology and molecular biologic aspects. Acute retinal necrosis had characteristic clinical picture comprising of the necrotizing retinitis in the periphery, vitritis, retinal vasculitis. This is a montage fundus picture showing peripheral necrotizing retinitis. In 1982, Culbertson et al. Described the histopathology and etiology of a case of acute retinal necrosis who, after 18 days after the presentation, the eyeball was available, and the histopathology here showing the inflammation of the iris and ciliary body. And there is the optic nerve lesion showing the chronic inflammation of the optic nerve with the necrosis of the retina overlying it, and there is the occluded blood vessels with chronic inflammation surrounding it. And here is the showing necrotic retina with complete loss of retinal architecture, and there is the inflammation of the choroidal vessels with thrombosed retinal vessels. And here is the full thickness retinal necrosis with the sharp demarcation line between necrotic and non-necrotic retina, normal retina. And there is a diffuse infiltration of lymphocytes in the choroid is seen. And this slide is showing eosinophilic internuclear inclusions seen on the section to the retina. And there is a total necrosis of the retina with inflammation in the choroid as well as the overlying sclera. Here is that episcleral vessels surrounded by the mononuclear cell infiltration with areas of retinal necrosis is seen. And electron microscopy showed herpes group of virus particles amid the cellular debris. And higher magnification showed internuclear inclusion shown in the arrows. And there's the envelope extracellular viruses were seen adjacent to the rod cytoplasmic membrane. We did a histopathological and molecular biologic study of an eyeball of a case of acute retinal necrosis, histopathologic molecular biologic study and immunohistochemistry which showed histopathology chronic non-granulomatous inflammation in the retina with occluded retinal blood vessels and herpes virus inclusion body. Nested PCR was positive for varicella zoster virus. CD3 positivity was seen on immunohistochemistry. This is a photograph of the other eye showing acute retinal necrosis in the periphery. And this is a histopathology showing the peripheral retina, showing chronic inflammation with occluded retinal blood vessels, which is seen on the higher magnification. The inflammatory cells were CD3 positive, there is a T cell positivity. Viral inclusion bodies were seen in the sections, and the nested PCR and real-time PCR showed herpes zoster virus DNA. Cytopathology of the vitreous specimen in acute retinal necrosis demonstrated a lymphocytic response with histiocytes, macrophages, and polymorphonuclear leukocytes. The studies suggested that both innate and adaptive immunity are responsible for the clinical disease findings. And here is the slide of the cytopathology showing that the hematoxylin eosin stain, infiltration of the lymphocytes and macrophages. Macrophages were seen on immunohistochemistry with CD68 positivity, and T cells predominantly seen with immunohistochemistry with CD3 positivity. Sparse B cells were seen, which are CD20 positive. And there is a cytopathology of the vitreous specimens showed collection of lymphocytes and macrophages. We did the correlation of quantitative polymerase chain reaction with clinical characteristics of patients with viral retinitis. We found that the DNA copy number significantly correlated with the extent of the clinical involvement. Real-time PCR was useful in confirming the viral etiology in over 50% cases of suspected viral retinitis. It correlated with the extent of the clinical involvement and the timing of the sampling. This is a case of acute retinal necrosis with 3-quadrant involvement of retinal necrosis, and real-time PCR showed 47,723 copies of the DNA. Non-necrotizing herpetic retinopathy. This is a 59-year-old one-eyed man, came with sudden blurring of vision in the left eye for 5 days. He lost his right eye 40 years back, and there was a granulomatous precipitation in the anterior chamber, and there is a retinal vasculitis with retinal infiltrate. Anterior chamber tap was positive for the herpes simplex virus type 2. Real-time PCR showed true crore 83 lakhs 1,985 copies of the herpes simplex virus DNA. CMV retinitis has got characteristic picture with a granular whitish patch, necrotizing retinitis with hemorrhages, perivascular distribution, sharp granular border, and often giving rise to the pizza pie appearance. And untreated end-stage CMV retinitis showed extensive retinal thinning with gliosis and sclerosed vessels, optic atrophy. Here is an autopsy eyes of CMV retinitis, and you can see that full thickness retinal necrosis with sharp demarcation between the non-necrotic and necrotic retina. And higher magnification showed cytomegalovirus inclusion bodies seen within the necrotic retina as well as in the retinal pigment epithelial cells. Progressive retinal necrosis comprises of multifocal necrotizing retinochoroiditis, which begins in the posterior pole and spread to the peripheral retina. There is an absence of vascular inflammation, minimal retinal hemorrhage. Optic disc can be involved with papillitis or neuroretinitis. There is no anterior chamber or vitreous reaction, no vasculitis, optic nerve involvement, and poor response to the treatment. Varicella zoster virus was postulated to be the causal agent. Close temporal association with the cutaneous zoster has been found. Cytomegalovirus we have found in the vitreous humor of one patient of progressive outer retinal necrosis. Here is a case of progressive outer retinal necrosis showing the necrosis of the retina from the posterior pole to the periphery with sparing of the vessels. An agarose gel photograph showed amplified product of the varicella zoster virus in the anterior chamber tap. And this is a case of where cytomegalovirus detected from the vitreous humor in a patient with progressive outer retinal necrosis. In case of molecular diagnosis and ocular imaging of West Nile virus retinitis and neuroretinitis, which has been described by Dr. Ratnam Shivakumar from Madurai, and there is a retinitis, retinal vasculitis, and neuroretinitis seen, and there is extensive retinal vasculitis seen in the fluorescent angiogram, and optical coherence tomography through the retinitis patch showed hyperreflective inner retinal layer, demonstrating inflammation of the superficial retina. And here is a case of acute neuroretinitis with macular star, which resolved with treatment. And there is a combined central retinal artery and vein occlusion in a case of West Nile virus infection. Dengue retinopathy, there could be anterior chamber inflammation or vitritis, chorioretinitis or hemorrhagic retinopathy, chorioretinitis with maculopathy, focal chorioretinitis or choroiditis, retinal edema, vascular sheathing, retinal hemorrhages, foveolitis, cotton spots, neuroretinitis. Here is the case, image courtesy of Dr. Padma Malini from Bangalore. This is a 21-year-old female with blurring of vision on the left eye for 3 days, history of fever, vision right eye was 6.6, left eye was 6.24, and you can see the retinal vasculitis with retinitis with hemorrhages. Optical coherence tomography showed hyperreflectivity in the outer plexiform layer, Henry's layer, and outer nuclear layer, which ultimately localized disruption of these layers. And this the dengue IgG was positive in this case. Post-treatment optical coherence tomography showed resolution of dengue foveolitis lesion. One-step real-time RT-PCR assay can be done to the serotype dengue virus with clinical samples. Chikungunya retinitis can present with mild vitritis, retinitis with or without macular star, retinal hemorrhages, retinal edema, multifocal choroiditis, neuroretinitis, optic neuritis can resemble West Nile virus retinitis or herpetic viral retinitis. Real-time quantitative polymerase chain reaction in the diagnosis of viral retinitis is quite useful. This is one of the example of a 48-year-old male came to our institute with gradual progressive dimness of vision both eyes since 15 days. Only history which was giving the patient was history of fever 3 months back. Fundus showed the multiple areas of retinal exudates with hemorrhages. And we did the PCR for all viruses. Chikungunya came with 9 copies of the chikungunya virus. And the patient was post-treatment with the steroid, showed complete resolution of inflammations with the hemorrhages and exudates. The vision improved. Clinical pathological study of retinal and choroidal biopsy in intraocular inflammation can be done in diagnostic dilemma. And this is a series of endoretinal biopsy of 24 cases where electron microscopy, in situ DNA, and polymerase chain reaction was done. Viral retinitis was identified in 53% of the cases, which comprises of the CMV retinitis, ARN, and progressive outer retinal necrosis. This is a case which was initially diagnosed as cytomegalovirus retinitis. When the patient was resistant to the treatment, retinochoroidal biopsy was seen, and here is the retinochoroidal biopsy showing necrotic retina with Toxoplasma gondii cyst. Electron microscopic study showed Toxoplasma gondii bradygioids. Polymerase chain reaction-based assays of the vitreous samples can be used for the diagnosis of viral retinitis. This is a study of 37 patients of 38 eyes. 24 patients, 63% had viral DNA. The CMV, 11 patients. VZV, 8 patients. Herpes simplex virus, 6 patients. 13 patients did not have any viral DNA. A new era of uveitis has come with the usage of multiplex PCR and real-time PCR. This is a slide from Dr. Mochijoki, and here is that 12-tube multiplex PCR strip coated with the primers can detect, distinguish between the fungus, mycobacteria, and virus at one go. In summary, the histopathologic studies provide correlation with clinical features, helps to understand the etiopathogenesis. Molecular biologic study of intraocular fluids in viral retinitis is helpful for diagnosis. Real-time PCR correlates with extent of inflammation. Endoretinal biopsy can be done to clinch the diagnosis in recalcitrant cases and in diagnostic dilemma. Thank you for patient hearing.
So thank you, Dr. Biswas, for covering the entire viral retinal necrosis in terms of molecular diagnosis and cytopathology. So we now move on to the next talk by Dr. Behram Budagi, who will be talking on necrotizing retinitis, its clinical presentations and differential diagnosis.
Thank you very much for the kind invitation, and I will try to concentrate on the clinical presentations and differential diagnosis of viral retinal necrosis. With this, I would like to thank IUSG and, of course, pay tribute again to our friend and colleague Manfred Zierhut, who started these webinars, and they are very successful. Now, just to start, and you have seen previously by the two speakers that this is a major infectious entity in our clinical setting, and it's an absolute emergency situation in patients with uveitis. When you deal with somebody with acute retinal necrosis, you have to be very, very cautious, and you have to act very rapidly. Herpes viruses are, of course, important, but we have also emerging diseases with a high rate of complications and, unfortunately, a poor visual outcome. This is why we need to know a little bit better these herpetic eye diseases involving the posterior segment. And as you may see, if we go to the group of retinopathies, we have the necrotizing group of retinopathies with acute retinal necrosis syndrome, progressive outer retinal necrosis syndrome, CMV retinitis, and with the acute retinal necrosis syndrome, we have either peripheral multifocal infections and foci of necrosis or central. And we have also the non-necrotizing herpetic retinopathies. This was, as said before, first described in Japan in 1971, and it was named the Kirisawa's uveitis. You have the principal clinical characteristics here with acute uveitis, retinal vasculitis, obliterative, with confluent yellow-white lesions at the level of the retinal periphery. And then came up the description by the American Uveitis Society of the clinical criteria. This was at that time based only on clinical manifestations and, of course, the exclusion of other diseases. And you see here again the very characteristic presentation, clinical presentation of the disease. I would say that even if it's, of course, very rare, but we have to know Arn syndrome, as I said. We need to check vitritis, which is very common and very aggressive in these patients. It's very dense with acute anterior uveitis in immunocompetent patients usually, but also in some immunosuppressed patients. It's bilateral in 1/3 of cases, and it may become bilateral after 1 to 4 months, but sometimes after years. I have seen a patient with the involvement of the other eye about 50 years later. Recurrences, however, are rare in the same eye. However, it may be possible. This is just a presentation of the anterior segment of one of these, two of these patients with, as you may see, characteristic KPs in this granulomatous presentation. And this is, of course, with the summary of what you can see as a catastrophe with a 360 degrees retinal necrosis. But look at, of course, also at the arteries. And you see that there is no more circulation within the arteries. And this is why the prognosis will be very poor, because you end up with healing the peripheral necrosis, but you will have an obliteration, which will give you, unfortunately, macular atrophy at the end and a poor vision. These are a few other presentations, as you may see here. Again, periphery with the necrosis, hemorrhage, and also retinal vasculitis. But in some cases, it may be more central. You have, again, here, occlusion of the arteries. And this patient was first referred for a Behçet's disease, and it was not a Behçet. It was an acute retinal necrosis syndrome. And in some cases, you have very small foci of retinal necrosis, which then will become confluent, and you will have the 360 degrees necrosis if you are not acting very rapidly and treating them. Some cases of central acute retinal necrosis syndrome, like here in a young patient with a VZV infection. And here, another case in the only eye of a child who already lost her right eye. And as you may see here, it's a little bit more difficult because the area of necrosis is just here. You may see it with the fluorescein angiography. And we treated her very aggressively and rapidly. And this is what you see as when the disease healed. Here, the foci of healing, with the 2020, fortunately, 2020 vision at the end. The group of Jennifer Thorne has done a great work in a series with the clinical outcomes. And in this series, all the patients were the PCR positive. And as you may see, the disease is mainly involving females, and it's mainly in African Americans and Caucasian patients, even though you find it everywhere in the world. It all depends, I think, not only on immunosuppression, but it may be a slight immunosuppression, which is not yet well known. Maybe we can discuss that later. What we see as complications, of course, you will find the visual acuity loss, but also retinal detachment is a real complication. We'll probably discuss that later on, but you have also epiretinal membranes and optic atrophy in 15 cases, as you may see in this series of more than 30 patients. Then we have this revisiting of the criteria by our Japanese colleagues, and that was very interesting. It was done in 2015 and 16. And these are the criteria. You see that the 6 first criteria are just clinical. The 5 following are on the clinical courses of retinal necrosis. And then they have also introduced the results, and this was the first time they introduced the results of virologic testing. That was, I think, really important because in most of these patients, in let's say 95% of these cases, if you do an AC-TAP or a diagnostic vitrectomy, you will confirm the presence of a specific virus. The results allowed them to distinguish between virus-confirmed acute retinal necrosis and virus-unconfirmed acute retinal necrosis, with a sensitivity and specificity which is pretty fair. And you see that they have combined these criteria and end up with a very good classification and criteria. This is the last one published by the Sun Group. This is the classification criteria for acute retinal necrosis. And I would say that this is more, we find exactly the same criteria, but it's more dedicated to clinical research of patients with acute retinal necrosis. But again, we will find the clinical manifestations and also the positivity of PCR, either in the aqueous or vitreous specimen. And what is important here to underline is that we have to eliminate syphilis in these patients. We have other types of manifestations, like here, a branch retinal artery occlusion of the right eye, starting first in an old patient, and then a few days later, you have acute retinal necrosis in the left eye. And this is important, of course, to consider. We have published years ago another setting, which is the catastrophic acute retinal necrosis syndrome associated with diffuse orbital cellulitis. This was a case report, and this is the histopathology of the orbital biopsy showing that it was a viral disease. Now, going from acute retinal necrosis to rapidly progressive outer retinal necrosis syndrome, this was first published and described in 1990 in immunosuppressed patients, and mainly patients with AIDS. It's different from the acute retinal necrosis pattern. It's a full thickness retinal necrosis in the posterior pole and the mid-retina, and going to the peripheral retina. Retinitis is rapidly spreading peripherally with multiple areas of various size, but you don't have vitritis as you used to have it with acute retinal necrosis syndrome, even though here it starts at the posterior pole, and you have a mild anterior uveitis. The difference with ARN is that it's bilateral in 71% of cases, and you have optic neuritis and vasculitis, which are rare. The visual prognosis is even worse than acute retinal necrosis syndrome. The third entity is CMV retinitis, of course, mainly in AIDS patients, but nowadays in all patients with immunosuppression, either therapeutic or by disease. And it's also seen in some patients undergoing corticosteroid injections into the vitreous. There are different forms of CMV retinitis. This one is necrotic with hemorrhage. You may have a granular form with less hemorrhage. These are two forms with, again, severe cases with retinal necrosis and hemorrhage. And this is a case of, unfortunately, a bilateral CMV retinitis, the posterior pole of a child, a newborn with CMV infection. I'm sorry for the quality of the pictures, but it was difficult. And the last presentation is the frosted branch angiitis associated with CMV retinitis, again, mainly in immunosuppressed patients. We have very rare cases described and reported of acute retinal necrosis after live zoster vaccine. I think this is important to consider. And if a patient comes to you with an acute retinal necrosis, it's always good to ask if there was a vaccination before. And now going to the differential diagnosis of what I showed you, again, you have here a typical case of acute retinal necrosis syndrome, and here a typical case of toxoplasmosis. This is the first differential diagnosis. You may have some cases of extensive peripheral toxoplasmic retinochoroiditis, like here, which may masquerade as an acute retinal necrosis syndrome, but it's a toxo. Here, again, another case of peripheral toxoplasmosis. Here, a case which is really looking like acute retinal necrosis syndrome due to a virus, but it's syphilis. And here, a case of retinal necrosis with dense vitritis, which finally was due to Aspergillus infection. Other presentations, again here, another case of toxo, which was diffuse and multi-spot. Here, a case of retinal necrosis and hemorrhage due to Behçet's disease. Here, a case of toxocariasis, peripheral toxocariasis. Here you have a cryptococcal infection of the optic disc, which is masquerading as a CMV retinitis. And here, a case of Porcher's retinopathy. These are a few slides that I took from Professor Luang, showing you in the upper tree, you have viral retinitis, and in the lower tree, you have intraocular lymphoma, which is the last differential diagnosis of acute retinal necrosis syndrome. They are arboviruses giving a few presentations of retinal necrosis and viral involvement. Here, the West Nile virus infection, chikungunya, which was already described by Dr. Biswas, and here dengue virus with retinal vasculitis. There are also other type of viruses, such as hand, foot, and mouth disease, giving you this kind of unilateral acute maculopathy. And also Ebola virus, as described by our colleagues Stéphane Ye and collaborators, with different presentation at the anterior segment, but also at the level of the retina with this catastrophic viral infection. Also, Zika virus can give you some congenital, but also acquired involvement of the posterior segment with the necrotizing retinopathy. And this is another case which is really progressing very rapidly. And as you see here, in a few days, the patient is becoming blind. You see very few foci of necrosis appearing here. This case was published by our colleagues, Professor Tugal Tutkun, and it's a subacute sclerosing panencephalitis, which is a real catastrophe because it may end up with the death of the patient. And it's a delayed form of reaction to the measles virus. To summarize, I would again stress the fact that this is an absolute emergency. It's site-threatening despite appropriate treatment and depending on the host immune status, different entities with similar clinical presentations, the importance of virological diagnostic confirmation, and the therapeutic approach, which should be adapted to the severity of each case and initiated without delay. With this, I would like to acknowledge all of my friends and colleagues from the Pitié-Salpêtrière Hospital. Thank you.
Thank you, Dr. Bahram. That was excellent. So with this, we now move on to the next talk on imaging biomarkers for necrotizing retinitis by Dr. Anirudh Agarwal.
Very good evening. Thank you, IUSG and the Education Committee for this opportunity. I will be talking about the imaging markers in necrotizing retinitis. So we all know that the diagnosis, and this has been well spoken in the previous conversations, the talks about the diagnosis of VZV, HSV, as well as CMV retinitis. And this will be my focus of the imaging talk. We all know that for the diagnosis of VZV and HSV necrotizing retinitis, we have three clinical parameters that we talk about. One is the acute panuveitis, occlusive retinal vasculitis, which is often an arteritis, with or without retinal hemorrhages, and finally, the peripheral patchy necrotizing retinitis. Sometimes this necrotizing can be multifocal, and you could have associated retinal breaks and optic disc swelling. On the other hand, CMV retinitis is often associated with immunocompromised patients with either a known HIV infection or other immunocompromised states, including malignancies or drug-induced immunosuppression, in addition to clinically compatible necrotizing lesions. Now, in general, when we encounter necrotizing retinitis, we have recently been working on a stepwise approach for fundus imaging in the diagnosis of posterior uveitis. And I'd like to generally divide patients which are presumed viral necrotizing retinitis into two categories. One, who are amenable to OCT, and second, the lesions which are not amenable to OCT, either due to media haze or because of extreme peripheral location of the lesions. In general, if you feel that the lesion is amenable to OCT, the first step in the imaging I would like to first do is an OCT. And on OCT, we can have several patterns, which I shall describe, but most often you find either a full thickness retinitis or a cavernous retinitis, which has been described in CMV. On the other hand, if you cannot do an OCT previous talks, especially Dr. Bodagi, has shown how you can actually do fluorescein angiography and look at the retinal vasculitis and retinitis with hemorrhages. I'd just like to focus a bit on CMV retinitis here. And CMV retinitis does present with full thickness retinitis, and the necrotizing variety of CMV can often be indistinguishable from the VZV and HSV patterns. Now, there are certain findings in CMV retinitis on OCT, and these include the hyaloid thickening and cells which present as hyperreflective dots along the posterior hyaloid, and I'll show you some OCT scans. But in general, there are two patterns of retinitis based on OCT that have been described in CMV retinitis, and these include a full thickness pattern which has hyperreflectivity affecting all the retinal layers, but in general, the choroid is preserved. And second is the cavernous pattern, in which there is severe retinal destruction, especially the outer nuclear layer, with a very large optically clear spaces which are with hyperreflective bridges connecting the necrotic retina. So I'd like to acknowledge my friend Alessandro Invernizzi, who has worked extensively on these OCTs. And on the top, you can see that you have significant amount of vitritis in patients of CMV retinitis, especially if they are not immunocompromised. So of course, if the patients are immunocompromised, you may not see so much vitritis. But in general, if the patients have an intact immune system, you can have a nebulous vitritis with sort of volcanic eruptions. And these volcanic eruptions, as you can see in the panel C, are nothing but these number of cells which are coming up from these stalagmite-like deposits on the pre-retinal surface. So you have a significant amount of vitritis if the immune system is active again. But in general, if you see the premacular bursa, or the area which is below the posterior hyaloid, is usually clear. And this is not the case in toxoplasmosis. In toxoplasmosis, usually you will have significant vitreous cells both in the pre and the post the hyaloid layer. So in both the regions, you will have a significant amount of vitreous cells. Now, as you can see, there are two patterns of CMV retinitis, and the first one on top is the full thickness type of CMV retinitis. And one of the feature there is presence of swollen RPE cells. So you can see the RPE cells are definitely hyperreflective, thickened, the layer is increased, and there are vertical strips, as you can see over here in the panel number 1. You have these vertical strips which are running from the outer retina, and we presume these to be either Mueller cells in the pathophysiology of the viral retinitis, or they could actually represent also the pathway of the virus infecting the retina. We are not sure. So the cavernous type of retinitis is the second pattern, which has number of optically empty spaces. And you find that there is a lot of loss of retinal tissue, and you have bridging retinal tissues connecting the remnant retina, connecting the inner retina to the RPE. And we believe that these patterns of the retinitis are the ones which can predispose to rhegmatogenous retinal detachment. So I think we still have lots of talks coming up on the management. And it's possible that if you identify this kind of a phenotype on OCT, there may be a role for prophylactic vitrectomies, because these patients are very, very highly likely to develop rhegmatogenous detachments. Moving on, so this is another, inactive stage. So when the full thickness retinitis heals, as you can see on the top panels A and B, the retina is almost flat. There is significant disorganization. But if you compare it with the panel C below, here you have significant loss of the retinal tissue, and you have these cavernous kind of bridges which form. And sometimes you have such kind of retinal breaks that can develop and predispose to rhegmatogenous detachments. So this is another patient here showing you a patient of acute retinal necrosis because of herpes simplex. And you can see that this patient has some very general features on the OCT, nothing very specific. You find that there is retinal thickening, disorganization and hyperreflectivity, vitreous inflammation. Sometimes you can also have intra or subretinal fluid. In general, intraretinal fluid is more common in viral retinitis compared to toxoplasma. So what's new in the OCT of viral retinitis? And this is something which was done by Alessandro. He was leading the study, and I was fortunate to be a part of it, published in British Journal of Ophthalmology. And as I said, we found that intraretinal edema was seen in almost half the patients of viral retinitis. So it's very common. And we already described some of the hyperreflective vertical strips in the outer nuclear layer. Again, very common finding in necrotizing retinitis, including HSV and VZV. Sometimes you can have these hyperreflective bridges or lacunae, and both of these are possibly signs where you can develop rhegmatogenous detachments. Now, choroidal architecture disruption is almost 0% in eyes of viral necrotizing retinitis. And this is something which is very important if you are distinguishing from toxoplasmosis. In the previous talks, we've already seen that toxo can very much mimic viral retinitis. And so I think this OCT feature is really important in distinguishing between the two. So if you see this patient on top is an OCT of CMV retinitis in an HIV positive patient, and you see that there's so much necrotizing retinitis, but the choroid seems to be completely normal. And on the other hand, you have another patient of CMV retinitis where you have significant retinal destruction, but the choroid is completely intact. So the key feature here is that you have this intraretinal fluid and these vertical strips, as we've already described. These are key features of viral retinitis. And in fact, what you will not see in viral retinitis is the choroidal hyporeflectivity, which is an important feature of toxoplasma retinitis. So again, I'll repeat toxoplasma, you'll see retrohyaloid cells, choroidal hyporeflectivity because of the chorioretinitis, and sometimes you have these stalagmite-like deposits. They're not specific for viral or toxo, but they're more commonly seen in toxo. I'd just like to end with one simple case of a 33-year-old patient who presented with, he had a combined disease, so an ocular disease and and large adrenal glands bilaterally. So he was diagnosed with congenital adrenal hyperplasia and was on steroids. So 5 milligrams prednisolone and 0.1 milligrams fludrocortisone daily. So this patient presented with 20/60 vision in the right eye, and the right eye had vitreous cells, and there are these lesions which you can see in the periphery with arteritis, and of course there is an occlusive vasculitis. So this patient of acute necrotizing retinitis was, as you can see, it's a 360-degree retinitis involving almost all the circumferential fundus. So the diagnostic possibilities, of course, we've already talked about it in the previous talks. You think about ARN, toxoplasma, and lymphoma, and you keep lymphoma as the last possibility always. And you can see the OCT here. The infrared shows you the retinal vasculitis on infrared imaging. So infrared is very useful to see retinal vasculitis. And you have these stalagmite-like deposits. They are much more common in toxo, but you can see them in viral. So this patient had this peripheral kind of bridging retinal tissue. And again, we know that these are the patients who can be predisposed to retinal detachment. So there's a full thickness retinal necrosis as well. So these bridging retinal tissue with loss of layers, and this patient did not have choroidal involvement. So it was against toxoplasma. And you don't have the features of lymphoma. And I'm not going into those details, but in general, in lymphoma, the retinal tissue is very much thickened and diffusely enlarged. So this patient, of course, received all the treatment, including antiviral therapy, intravitreal foscarnet. But again, this patient improved. As you can see, the retinitis lesions are healing. But the patient came back 1 month later with a retinal detachment. And you can see in the exact same area where you had the bridging retinal tissue, the patient developed sieve-like retina, large retinal breaks in the temporal periphery. And so the OCT now shows you a detachment. And this patient underwent vitrectomy with buccal and silicon oil, and the fluid was sent out for culture. But at this time, the PCR, of course, was important to do because you want to rule out CMV, which is very common in patients of congenital adrenal hyperplasia. And of course, you will manage patients of CMV differently compared to patients of HSV. So again, the take-home point is that these patients, not only you do OCT to look at the diagnosis of viral retinitis, but also to distinguish from other causes of necrotizing retinitis. And you can predict and prognosticate the retinal tissue loss or predict kind of a retinal detachment. Thank you very much again for the opportunity. Thank you.
Thank you, Anirudh, for the imaging biomarkers, very nicely shown. So with this, we now move on to the next talk by Dr. Mark D. Smith, who will be talking on the laboratory workup in viral retinitis. So we have a pre-recorded talk by Dr. Mark D. Smith.
Thank you. It's a pleasure to be part of the webinar series again, and I'm sorry I'm not present because I have a conflict with another meeting. I'll be talking to you about laboratory workup in retinal necrosis. And as we start, I'd like to point out, and I will a few times, that the treatment, the priority here is really treatment above diagnoses. We'll talk a little bit about which exams and when, and a little bit about other differential diagnoses to consider. These are typical presentations. You might just have a patient that has a conjunctivitis initially and maybe a papillitis, but most commonly you'll see a confluent area of whitening in the periphery, a thickened retina that may cause the shadow, as you can see down here on the left. And it may be in more than one quadrant. The danger here is that there can be a fairly rapid extension, and vitritis may be variable. But if you think you're dealing with acute retinal necrosis, getting treatment early is really the most important thing you can do. Now, if you have a more aggressive form, such as this one, which is inner necrosis of the retina, you should even be more aggressive with regards to your treatment and probably not even waste a few hours. If you're suspicious, do the treatment, assess the progress, and yes, if you're going to do laboratory testing, it may help you in being able to switch therapy if there's not a good response. But if response is really what you expected, there is in fact no reason to necessarily go on to further treatment. Time is of the essence. Now, if you have a retinitis and it is viral, PCR is the way to go. But if there's any doubt in terms of the diagnoses, and you may be dealing with toxoplasmosis, the PCR is not always positive, and there doing a Goldman-Wittmer quotient can be useful if in fact it is available in your area. As you can see here, quite a few of the cases in fact had a positive Goldman-Wittmer but had a negative PCR. Overall, with regards to should we use the anterior chamber or the vitreous, in fact, both are usually adequate. Most studies will give you maybe a slight preference for one or the other, but the most important thing really is to try and obtain a sample in a setting where there is at least a little bit of inflammation. There is no delay with regards to positivity. Even within a week of the initial symptoms, you should be able to get a positive response, and it will carry out during the period of activity. And you may even have cases where there is more than one virus present. Using qPCR, you will see that if you have a higher involvement in terms of quadrant, there's a higher viremia. Whether you're looking at CMV, HIV, or VZV, notice that in this particular case, not all cases were positive with PCR. So there are certainly situations where you either need to repeat the test or really use your clinical acumen to know whether the patient is responding adequately. There are newer types of PCR, for example, the Luminex, which may be able to give you a higher sensitivity and even be able to detect when there is more than one virus present. And so it's important to see which technique is being used in your laboratory, or if you have several laboratories available, try to use the one that has the most sensitive technique in order to reach a diagnosis. Some of the newer approaches that are being looked at are, for example, the use of AI, where by using different combinations of interleukins, interferons, macrophage markers, and T-cell markers, one is able to obtain a profile for different types of intraocular diseases or pathologies. And so using AI, you're able to quantify a little bit the profile of different types of cytokines. And with regards, for example, to acute retinal necrosis, the presence of the interferons is very important, as well as MCP1. And by doing so and using different approaches, you can get a number of predictions. So a first order prediction, second and third. And if you combine all of these, acute retinal necrosis comes out very high, up to a 92% probability based only on the cytokine profiles that are present inside a vitreous sample. So for the future, this may be a very interesting approach because it helps to differentiate what you have inside the eye from cases of, for example, endophthalmitis or other forms of uveitis that might be present. Even more interesting, I think, is potentially the use of quantitative PCR to look at viral load. This was done on anterior chamber in a protocol where patients were treated very aggressively with antiviral agents intravitreally twice a week until there was a disappearance of the acute retinitis or the patient had developed a retinal detachment. Intravenous ganciclovir was given Q8 for 14 days, followed by oral valganciclovir for a prolonged period of time. And what was found was that the virological parameters were associated to in terms of outcome to the initial viral load. And they were also able to look at, in fact, the profile over time. They saw that there was, in the kinetic of response, first a plateau phase that was followed by a log decline. And once a log decline of 0.5 or more was noted, this was considered, in fact, a good response. It was initially seen at 1 week in about a third of patients, in the first and second week in another half of the patients, and there was just 1 or 2 patients where it took about 3 weeks, and by 4 weeks there were no detectable viral particles inside the anterior chamber. And so this is probably an interesting way to be able to follow response to therapy in patients if we repeat the quantitative PCR. And notice, for example, in patient 2 and patient 7 here, that there is a spike, first an increase before there is really the decrease that we've just described. So for laboratory testing, no delay. For viral causes, PCR is certainly sufficient. Anterior chamber vitreous is certainly acceptable. Repeated samples may give you, in fact, some degree of response. And if there's a chance that this is non-viral or there's not a good response, yes, Goldman-Wittmer would be useful, looking at IgG or IgA. Sometimes IgA is better. At the level of the blood, looking for example, IgM in toxoplasmosis may be useful. Those are often the cases that present looking like acute retinal necrosis. So the most common causes, as you know, is HSV, VZV, or CMV. The ones that occasionally can be confounding are toxoplasmosis, HTLV1, measles. These are cases here. The first up to the left was in fact a VZV when we tested it. The one up to the right looks like a acute retinal necrosis, but was in fact lymphoma, so completely different diagnosis. The two cases below were in fact toxoplasmosis. On the left was referred in with the diagnosis of a likely VZV, but on vitrectomy we're able to show also on systemic testing that IgM for toxo was very high. And on the right, it's thanks to a vitrectomy to try and diagnose what the process was and obtaining histology that showed us essentially here by cytology that we had a tachyzoide present inside the eye. Now, I've mentioned a little bit earlier that measles could be a problem. This is when you have outbreaks, and in children, you can develop subacute sclerosing panencephalitis. It gives you a retinitis at the very back of the eye that leads a bit to a pigmentary change, a thickness. There is no inflammation present in the vitreous, and usually within a month, they start developing the encephalopathy, which is typical of this disease. But should it take longer, there are cases of VZV retinitis that have been described in the posterior pole, and a biopsy might be necessary. Biopsies in the posterior pole don't necessarily need laser. In this particular case here in the periphery, since you don't necessarily need to get a biopsy of the choroid, so you would try to get partly retina as well, healthy as well as diseased retina. Other forms of viruses can give you something that could be similar, but again, location is here more central and not located in the periphery. But beware that there are other forms of viruses, so the rabies viruses that affects normally pigs, that can give you a complete a retinal necrosis with retinal detachment. And there are some bacterial infection that can also give you a necrosis that can be diagnosed usually either by PCR or by culture. Remember also that there are, with the use of Ossodex today, cases of localized immunosuppression that can lead to an activation of a acute retinal necrosis in the eye that has been implanted. Thank you.
So, thank you, Mark. So we now move on to the next talk by Dr. Behram Budagi, who will be talking on manifestations of chronic viral retinitis.
Thank you again. And now that we have seen all the basic aspects, except treatment, which will come after, I'm taking another topic, which is maybe rare, but which may be very difficult to manage. And these are the chronic cases of viral retinitis. I have no financial interest again. So I would say that we have a spectrum. When we discuss viral retinitis, we have a spectrum of clinical presentations, as you have seen, with association with different types of viruses involving the posterior segment with a variable degree of viral replication requiring rapid diagnostic confirmation. Use of corticosteroids in this setting of chronic viral retinitis may be necessary, even though you have to be cautious. Conventional immunosuppressors must be avoided, and we have the possibility to use immunomodulatory agents. We can propose them. So that's these are the main issues I would like to cover with you. Again, I want to remind you that we have 8 types of herpes viruses. Of course, you know the 1 and 2 HSV, VZV, CMV, but we have also EBV and HHV8, and I will give you a few examples. For the diagnosis of this kind of chronic viral involvement, again, PCR is very important, applied to aqueous humor and vitreous, but also we need to combine it to the Goldman-Whitmer coefficient evaluation at the level of the anterior chamber or the vitreous, because the PCR itself may not be able to confirm all cases, even though it's mainly the case when we have acute retinal necrosis or CMV retinitis. PCR is doing very well, but in the chronic cases, it's a little bit more difficult. Our group was one of the first to describe this type of non-necrotizing herpetic retinopathies, masquerading as severe posterior uveitis, because in the early 2000s, we wanted to identify viral agents, especially herpes viruses, in atypical presentations of intraocular inflammation. And you may see here a few examples of a patient with vasculitis, diffuse vasculitis, choriocapillaropathy, papillitis, in a case of herpetic viral infection. Here, a case of bilateral, very severe retinopathy with pigment epithelial alterations and macular choroidal neovascularization. This is what we had in fluorescein angiography of one of the eyes, and that ended up to be a CMV infection, a chronic CMV infection. And this is another case of viral retinopathy with papillitis and macular edema and vasculitis, which was masquerading as an MS type of uveitis, and which was an herpetic infection. This is another case which is related to HHV8 infection. It was a Kaposi sarcoma in a patient without AIDS, involving the anterior segment, involving the conjunctiva, and the diagnosis was based on after conjunctival biopsy, but also bilateral macular edema, papillitis, and vasculitis, more severe in the right eye. And in this case, the only way to control the disease and inflammation was the use of interferon alpha. There is another entity which is important to know, and this is the immune recovery uveitis. As you know, cytomegalovirus retinitis is associated with AIDS, as we have seen. And in the highly active antiretroviral therapy era, the incidence is estimated to be 5 to 30% of patients with pre-existing CMV retinitis starting heart. And this is mainly due to the fact that you have the presence of CMV antigens, even though the patient, the retinitis is healed, but you have still CMV antigens in the retinal cells, and you may have an inflammatory response to these antigens when you have immune recovery. This is why we are dealing with these cases where you have no more viral replication. You have always to check it, but usually you have no more viral replication, but you have intraocular inflammation. Here is a case of papillitis and macular edema on the left side in a patient with AIDS and immune recovery uveitis. And in these cases, with the permission of the infectious disease expert, we can propose local corticosteroids, periocular injection of corticosteroids, in order to control intraocular inflammation, which is secondary to CMV antigens, but you have no more CMV replication. Our colleagues from the Netherlands did a great work and published a little bit later this paper in archives on necrotizing and non-necrotizing variants of herpetic uveitis. And as you may see here, in their series, they have acute patients with acute retinal necrosis syndrome, patients with non-acute retinal necrosis syndrome, patients with slow type acute retinal necrosis syndrome, and you find again this category of non-necrotizing forms of acute of viral retinitis. And these are the clinical characteristics. As you may see, they are pretty obvious in the ARN. They compared the ARN and the non-ARN group, and you see that mainly the differences are not significant. You have necrotic retinal lesions, of course, in the ARN group, which is important, and less in the non-ARN group, and rapid progression of lesions, again, in the ARN group, which means that the other one is smoldering, and you have to pay attention to that. This is why many of these patients are treated with corticosteroids and immunosuppressors, which is, of course, not the appropriate treatment. This is the confirmation of the patients that you may see, VZV-HSV in the necrotizing form, the slow type ARN. Here in the group of vasculitis papillitis, which is non-necrotizing, and the group of panuveitis, again, you have mainly VZV in most of these patients. Now, how we can manage these cases of chronic viral retinopathies? They are reports on the successful treatment with injections of dexamethasone implant, for example, for recurrent macular edema after acute retinal necrosis. I would say that even though here you have a beautiful effect on macular edema, I would say that you have to be very careful, because viral replication should be completely under control. And there are other cases of acute retinal necrosis described after dexamethasone intravitreal implantation. So we need to really pay attention to this point. And corticosteroids are a double-edged sword, and they may be helpful, but they may also cause some increase of viral replication and retinal necrosis. Medical therapy of uveitic macular edema. This is a review in ocular immunology and inflammation under the chairmanship of Manfred Zierhut with the use of biologic agents. I like this very much, and this is a paper I would like to cite by our friends from Turkey on interferon alpha 2A for the treatment of cystoid macular edema secondary to acute retinal necrosis, because this is also exactly the strategy we use in Paris to treat these patients. This is just to show you that in these cases, the age is pretty common with what we have seen. And interferon was very active. However, many and most of these patients discontinued the treatment because of side effects. And it's not like Behçet, when people were adherent to interferon alpha therapy. In these cases, they discontinue, and every time you discontinue, of course, macular edema is getting back. These are the 7 patients. It was 8 eyes of 7 patients. And here you have a great example of macular edema. After interferon alpha therapy, you have resolution. And then when the patient discontinue, you have again reoccurrence of macular edema. So interferon is a great treatment. You have side effects, of course, but it can control macular edema if you continue to treat the patients. I think if you treat them for a long time, you can eventually discontinue, as we have seen in Behçet. But if it's just a short course, they will recur. Maybe in the future, the discussion will be on anti-IL-6 therapy, but I think it's too early to discuss this at this time. To summarize, I would again insist on the fact that herpetic infections of the retina are severe, devastating, and sight-threatening diseases. Of course, when you have an acute retinal necrosis syndrome, then you go immediately to treat him, the emergency, and using aggressive treatment. It's much more difficult when you have this chronic form, smoldering, with very late, devastating complications at the level of the posterior segment of the retina. Non-necrotizing herpetic retinopathies and post-infectious inflammatory reactions must be promptly managed. Therefore, you have to exclude viral replication, and this is why diagnosis and diagnostic technologies are important, again, to apply on on aqueous and vitreous fluids. And corticosteroids, as I told you, you have to be cautious, but they may be used in some cases. And again, immunomodulatory agents, you are taking less risk because interferon is not risking to increase viral replication. It's an antiviral agent, but it has also immunomodulatory properties, which may help you to control the disease. With this, I would like to thank again the IUSG for its invitation, and would like to invite you to the next International Ocular Inflammation Society meeting, which will be the 17th in Berlin. It will be in person from 6th to 9th of September next year. And this is the website. Thank you very much.
Well, thank you, Bebram, for the nice coverage of the cystoid macular edema. So this question was in our question and answers also regarding the management of persistent CME after AN. So we'll take up more detail in discussion.
Audiovisual team, can we play the next talk, please?
Hello. In this segment, we will be talking about retinal detachment surgery in acute retinal necrosis. We will be reviewing the clinical course in pathophysiology of acute retinal necrosis, in part because it's very important if we're going to plan and carry out surgery. We'll also look at when is the best time to intervene, and we'll also see what type of operation, at least from my own clinical experience, would be very useful. Now, during this whole session, we've talked about different forms of acute retinal necrosis, the diagnoses that are involved, but we also have to realize that this is a disease that has a certain evolution. It often presents first with a conjunctivitis and a certain degree of anterior segment involvement, as you can see above in the slides here. And it can form, in fact, a granulomatous response that is more or less visible. It very shortly after that, but the time is variable, often involves the optic nerves that can become swollen or show signs of papillitis. And at some point, we start seeing, in most cases, a peripheral whitening and thickening of the retina with the shadows that we've talked about earlier. And the vitritis that usually occurs at a slightly different time. So these are the different steps that occur with regards to the development of the disease. And if we recognize and are able to diagnose the acute retinal necrosis early enough, we might in fact not have that much vitritis. Once we start using the medications that will stop the process, it usually does so fairly quickly. But we have to realize that at the leading edge, there is probably part of that area of the retina that is already involved. As the disease progresses, there will be more and more vitritis that is present, and this may in fact lead to retinal detachment. Reason being is because initially in most of these patients, the vitreous is intact. As we can see in the ultrasound, there is in fact no PVD present. Inflammation as it develops will lead to a partial PVD, usually an anomalous PVD, where a lot of vitreous remains at the retinal surface while the vitreous itself separates, and as occurs in many uveitis cases, as they're very severe. The detachment is often around the optic nerve and may involve the macula and protect it in some ways. And the traction occurs usually in the areas of necrosis. These are the ones that end up very often separating because there is a relatively good adhesion of the vitreous, so that it's usually at that interface or beyond where the problem occurs. Retinal detachments usually occur late. It can be weeks to months, even after resolution of the disease, as the vitreous starts to condense more and more and leads to traction on the retina. There is, of course, a version that occurs fairly early, which is more an exudative retinal detachment. There might not yet be any tears present, and there the most important aspect is really to treat the disease rather than to do the vitrectomy, and we'll come back to it, the reason why. Now, we'll spend a little bit of time about histology, because if we look at, for example, the histology of the involved retina, it's in fact a diaphanous scaffold. Essentially, we have vessels that are left, and we have a completely dysfunctional retina at that level. It's in fact dead. There is, from an anatomical, or at least a surgical standpoint, no reason to try and maintain this retina because it's non-living. And if it isn't the way, it may be better to remove it rather than to try and spend a lot of time to remove vitreous, or maybe leave some vitreous behind, which ultimately may lead to a redetachment. The leading edge of retina appears normal but may be infected, particularly in the early stages where the antiviral medication has not yet had a chance to have a full effect. If we look at many series, that hasn't been studied all that well so far. Once medications have been given and have stopped the disease, there is only about 10% of spread into a new quadrant. And so this means that in general, at least over a period of time, if we wait long enough, the leading edge of normal retina is an area that we can treat with laser, but we should put sufficient rows in case there is still a bit of progression after we've completed our vitrectomy. Now, I show you this case because it shows you areas of involvement that are already infected with the virus, but at the same time, there are many surrounding areas that potentially might be infected. And so both in the image on the left, as well as this image that I'm showing you now, where you can see that there is more progression of disease, only the area between the optic nerve and macula here appears to be normal. And so if we had to do surgery in this particular case, laser would have to be placed fairly centrally. Now, this is not your typical acute retinal necrosis that involves the periphery. This is a case of progressive inner retinal necrosis, or what was used to be called PORN. It's a much more aggressive form and one that diffuses very quickly through the retina. And operating on a patient like this would be particularly complicated because most of this is necrotic retina. What about this case? It's a mixture between PORN and a typical RN. It is fairly central. And if you have to operate in this case, you would want to be able to try to treat aggressively first with the antiviral agents before you would even consider putting any laser or doing surgery. The natural evolution of acute retinal necrosis is, first of all, to cause involvement in the periphery. If we stop the disease with antivirals, we then can lead to stabilization. And it is only when we get 2, 3, or particularly 4 quadrants of involvement that we end up having an increased risk of having a retinal detachment, as is shown here on the right. And what is nicely outlined here in this image, taken in the 1970s, is the fact that what remains behind are these sclerotic vessels with atrophy of the retina, some contraction of the surface, and shrinking of the retina itself. And what's present in the periphery is essentially non-viable. Now, one important point that is not mentioned very much in articles when you look at reviews regarding surgery is the fact that the retinal circulation is compromised in patients that have acute retinal necrosis. And we're looking here at central retinal artery blood flow. And the blood flow is particularly limited. If you look at the study eye versus the control eye, looking at peak systolic velocity and end-diastolic, both are in fact significantly decreased. And this has an impact when you're trying to do your surgery. If you're using your normal intraocular pressure that you would normally use to do a vitrectomy, which is somewhere between 20 and 30, this is probably much too high if you want to be able to maintain good perfusion and vision in these eyes. It's not uncommon that even with 15 millimeters of mercury, if you look at the optic nerves, there is in fact pulsation. And so in general, for these patients, I try to operate about 10 millimeters of mercury and not much above. Now, we've talked earlier in the previous talk about viral load. And if we give an intensive treatment intravitreally as well as systemically, we find that we can reduce this viral load very quickly inside the vitreous cavity and in the anterior chamber. It usually takes about 1 to 2 weeks for most patients to become undetectable. And in most cases, you achieve this at 4 weeks. The reason I mention it is that if you started your antiviral treatment and you see that there's a retinal detachment, there may be value in waiting a little bit to allow these antiviral medications to work sufficiently before you go on to do your surgery. Laser will be effective only if you're looking at uninfected retina. Your surgery should be done when you have a good antiviral coverage. Diaphanous retina is non-functional. You might as well not leave it behind and put your laser in good retina so that you have a better chance of being able to keep the retina attached, because the rate of redetachment is not negligible. What are the main risk factors? The main risk factors is the initial vision that tells you how good the retina is performing, and to some extent the optic nerve, and the number of clock hours of retinitis. All the rest, whether it's age, whether it's the location in the posterior pole, the type of virus that is present, is not all that important. And in this meta-analysis that looked at many studies going from the 80s all the way up to 2020, we see that again, it's the quadrants that is most important. With one quadrant, you have about a 13% chance of having a detachment, 45% chance if you have a four-quadrant involvement. It's a good idea to treat with the systemic antivirals. It reduces your risk. In the same way, prophylactic laser will be able to reduce risk. And doing a vitrectomy early is also a protective phenomenon. And in this meta-analysis, yes, you reduce the risk of retinal detachment by doing an early vitrectomy, but it might not be quite as good with regards to the maintenance of vision. However, most cases in this particular meta-analysis done in the last 5 years were done in patients that probably had more risk and more advanced disease, where in fact preservation of vision may be more difficult. The goal of surgery is to remove all membranes that are present and all the vitreous that is attached to the retina. This is an anomalous vitreous. It's usually very sticky. It's a bit like what you find with myopes, but even thicker in these cases. You need to be very meticulous over the healthy retina and consider doing a retinectomy in the areas where you have atrophic retina, and again, keep a low infusion. All adherent vitreous needs to be removed. You could use triamcinolone to facilitate visualization. I certainly would recommend doing an entectomy because it's important to remove vitreous all the way to the vitreous base, since you could have traction in the periphery that leads to recurrent detachments. This is, you get a lot of fibrosis that is present usually along the ciliary body. You have to be very careful to remove all membranes that are present there. You would then put laser along all of the holes and along the areas where you've done the retinectomies, whether this is with perfluorine or oil. I would only use air when there is no inflammation that is present and it has fully subsided. Wait for a period until the inflammation has passed, if possible. Certainly make sure that there is enough antiviral present in that eye. The initial success is quite high, but there's a high level of recurrence. Buckles still is debatable. I would use them if there's incomplete removal of vitreous because of limitations in visualization, for example, not a complete retinectomy, and you need to support inferiorly, and you want to reduce the risk of further projection. This is the degree of removal of the retina that was done in one case that I've done some time ago. We used silicone oil. You can see that the laser is quite intense and also of a large area in order to ensure that we're able to maintain the retina attached. Carefully avoid intraocular pressure reach increases postoperatively. Aggressively manage the inflammation with topical and periocular injections of steroids. Continue your antiviral treatment as required. It depends on when the detachment occurs. And oil removal, when you do decide to do it, should be done with low infusion pressures. Thank you very much.
So with this, I move on to my talk next, which is on medical treatment of necrotic viral retinitis, including laser management. So thank you, ISG, for this opportunity. To be speaking on medical management of viral retinal necrosis. So coming to the antiviral agents that we use are acyclovir, valacyclovir, ganciclovir, valganciclovir, famciclovir, and foscarnet. So as these agents evolved for the use in viral retinal necrosis, their chronological order for the first that came was intravenous acyclovir, followed by oral acyclovir, and with the newer oral antivirals being equally effective, like valacyclovir and famciclovir, and the intravitreal antivirals, a new treatment regime has come up, along with the adjuncts which include steroids, anticoagulants, and laser photocoagulation. So acyclovir is a structural analog of the natural compound 2-deoxyguanosine. It's a potent and selective inhibitor of VZV, HSV1 to Epstein-Barr virus, and modest activity against CMV. Converted to its monophosphate by the virus-encoded thymidine kinase, and it's highly specific for herpes-infected cells and non-toxic to the unaffected cells. It is available for use in both oral and intravenous routes. The valacyclovir is the valine ester of acyclovir. It's orally administered. It's a prodrug which is rapidly metabolized to acyclovir and has a much higher bioavailability of 54% compared to that of oral acyclovir, which is only about 20%. And thus it involves a less frequent dosing regimen. Famciclovir is again an orally given prodrug, which is converted to penciclovir in the liver, good bioavailability of 77%, and it resembles acyclovir in chemical nature, mechanism of action, but the penciclovir is poorly absorbed, which is why famciclovir is used clinically. It's considered in cases of acyclovir-resistant acute retinal necrosis and is given in the dose of 500 milligrams 3 times a day. Ganciclovir is an inhibitor of viral DNA polymerase, which has activity against CMV as well as the herpes virus. It's given as intravenous or oral or intravitreal agent. In ARN, it is used as an additional intravitreal medication besides acyclovir. However, it requires pharmacy compounding. Valganciclovir has activity against herpes, varicella zoster, and CMV virus, successfully used for CMV retinitis in the dose of 900 milligrams twice daily orally for 3 weeks in the induction phase, followed by 900 milligrams once daily for the maintenance dose. Foscarnet is an effective alternative treatment in acyclovir-resistant herpes simplex or VZV strains because it does not get activation by thymidine kinase. Intravitreal injection or intravenous routes are available with this. It does not require compounding, and the dose requires no dilution from the commercially available intravenous solution. So coming to the background of how the antivirals started getting used for viral retinal necrosis, first it was described in 1986 in ARN with the successful use of intravenous acyclovir, which resulted in regression of all the retinal lesions and also led to reduction in the incidence of fellow eye involvement, which is reported in 1991. It is used in the dosage of 10 milligrams per kg every 8 hourly for 7 to 10 days. Some use it for 2 weeks, followed by the oral antiviral agent. And this is the most established treatment regimen. And now with the newer oral antivirals with greater bioavailability, we have a new treatment algorithm which includes initiation with oral antivirals and simultaneous intravitreal injections. So the oral treatment has largely eliminated the need for a hospital admission for intravenous medication. So coming to the systemic antiviral therapy, looking at the literature that reports the use of intravenous antiviral therapy. So the study that was published first in 1986 had 13 eyes, of which all showed regression of retinal lesions and 11 developed RD, but there were no systemic or ocular complications associated with this treatment. Followed by this came in 1991, where 14 patients were treated, and the fellow eye involvement was much less in the patients who were treated with intravenous acyclovir as compared to the ones who were not treated with intravenous acyclovir. Then again, a lot of literature came, and in terms, the comparisons were made in terms of fellow eye involvement, regression of retinal lesions, and improvement in visual acuity. So coming to the advantages and disadvantages of intravenous antivirals, the advantage is that we have the patient admitted with us. So we are giving the treatment under direct supervision. So we ensure a better compliance. It's cheaper than oral valacyclovir. And of course, it's much more suitable for the homeless and the elderly patients. The disadvantages include it needs hospital admission, and nephrotoxicity and neurotoxicity are known with the intravenous antivirals. Of course, there are cost issues with the hospital admission and the risk of hospital-related diseases. Coming to the oral antivirals, they've been reported to have comparable outcome with that of intravenous treatment. The advantage is that we can treat the patients on outpatient basis. They're equally effective for induction therapy, by and large well tolerated, and reach desirable concentrations in the vitreous, and now they're becoming very popular with simultaneous and intravitreal injections. So this is just some of the literature that started reporting the use of oral antiviral agents like valacyclovir and famciclovir with or without steroids. And it was realized that clinical improvement was there in majority of the cases. Retinal detachment started to get reported in much lesser number of patients. There was no involvement of the fellow eyes, and the mean time of resolution was 2 to 3 weeks in most of the cases. The adverse drug reactions, when we look at these antiviral agents, the oral ones are by and large well tolerated. IV acyclovir, of course, as I said, neurotoxicity and nephrotoxicity because of crystalline nephropathy. Higher risk of these complications among the immunocompromised individuals, and the general adverse reactions include headache, rash, and GI symptoms. And more of these immunocompromised patients are at risk of developing thrombocytopenia or hemolytic uremic syndrome. Coming to the intravitreal therapy, we have ganciclovir or foscarnet for this, mostly used as an adjuvant therapies to systemic antivirals, whether intravenous or oral. Monotherapy has also been reported with intravitreal ganciclovir or foscarnet in case reports, or even both of them have been simultaneously used as intravitreal treatment in few case reports. So the dose of foscarnet is 2.4 milligrams in 0.1 ml. And in this dose, it reaches excellent vitreous concentration, and it's recommended to be given 2 injections per week for the induction phase, and then can taper it to 1 injection per week. Ganciclovir, 2 milligrams in 0.1 ml, 1 to 2 injections per week initially, and when the lesions start responding, can continue with 1 injection per week. So in 2011, the adjunctive role of intravitreal ganciclovir along with intravitreal dexamethasone was reported in one patient. So coming to the systemic treatment and with their combination of intravitreal antiviral therapy, again, there were a lot of retrospective series, some involving only 3 eyes and some involving a large number of eyes. So it showed that the rates of retinal detachment were 40% lower in the group that received intravitreal foscarnet versus the group that did not receive intravitreal foscarnet. And combination therapy of this systemic with intravitreal injections led to a better visual acuity, better resolution of retinitis lesions, and lower rates of retinal detachment. As I said, foscarnet and ganciclovir, the doses recommended are these, and 2 injections can be given in the initial induction phase, followed by 1 injection per week. And maintenance phase, when the disease has regressed, only orals can be continued. So this is the treatment regime, which is by and large followed by most of the practitioners. Intravenous acyclovir, 10 milligrams per kg, 3 times a day for 7 to 10 days. Or if you don't want to admit the patient, oral valacyclovir can be given up to 2 grams TID with or without intravitreal ganciclovir or intravitreal foscarnet with the topical anti-inflammatory therapy depending upon the anterior segment inflammation. Once the lesions respond, the maintenance phase is given with, we switch to oral acyclovir 800 milligrams 5 times a day, or oral valacyclovir 1000 milligrams TID for 6 to 12 months. Now this range has varied everywhere. If we look at the series, some people give for 3 months to 6 months, some people give for 6 to 9 months, and people have given for 12 months. Now, prophylaxis, this answers some of the questions that have been put in the question and answers. Whether to give them lifelong in immunocompromised patients, yes, some clinicians do prefer to give it, but this topic is debatable and it will remain debatable because the fellow eye involvement has been reported as late as 20 years after the primary episode in the first eye. So the adjunctive therapy includes corticosteroids, which can be given oral or topical. They're given for the inflammatory response, which is usually severe in viral retinitis, and usually recommended to give 24 to 48 hours after initiating the antiviral treatment. But we need to administer the intravitreal steroids with extreme caution, because as you've seen in previous talks, these intravitreal steroids have been reported to be used for persistent CME after ON, but there are case reports of ON occurring after the use of intravitreal Ozurdex. So it's a double-edged sword. We have to be very cautious about the intravitreal dexamethasone. Antiplatelet agents include the adjunctive aspirin and warfarin. Given the extensive retinal arthritis and the retinal vascular occlusions that occur in ON, an acute decrease in vision resulting from ischemic optic neuropathy, because hyperaggregation of platelets has been reported in cases of ON. However, there is lack of strong evidence and it needs careful consideration. So this is again, there's a lot of literature about systemic steroids with or without antiplatelet therapy. And one series has shown that systemic steroids given before the diagnosis of ON or before initiating antiviral therapy did not really increase the risk of RD, and neither aspirin nor oral steroids affected the final visual outcomes. So the resolution was seen in all. So these are just adjunctive therapies. Coming to laser photocoagulation, the prophylactic laser is very controversial and is not always practiced. It's difficult to put laser in these eyes because of the extremely inflamed, painful eye, poor dilatation of the pupil, and media haze. It may even cause a rebound increase in inflammation in an eye which is already infected. And the inherent selection bias and limited evidence that we have do not advocate for the use of prophylactic laser at this point of time. So if you look at some of the series of laser photocoagulation where they have reported comparison of lasered versus non-lasered eyes, the incidence of retinal detachment was seen as 17% in lasered eyes versus 67% in not lasered. So if you look at these series, most of them have reported that the rate of retinal detachment was much less in the eyes that underwent laser. But there is a potential bias because eyes that were not able to undergo laser were the ones which were really bad, had a very poor media clarity, had more severe inflammation and more widespread retinitis. So they already had a poor prognosis. So that is the reason probably why the unlasered eyes developed more of retinal detachments. So coming to the progressive outer retinal necrosis, as we see, it's usually caused by the VZV. And in patients, these patients have varying levels of immune dysfunction because they are the ones who are immunocompromised. So intravitreal injections have been recommended along with systemic therapy in combinations. But the level of immune recovery at which the antiviral therapy in progressive outer retinal necrosis may be safely discontinued has not been established. Unlike CMV, where the CD4 count greater than 100 per microliter is considered as a safe parameter to stop maintenance treatment. So this is a patient just to show you that we saw in January 2022, coming with, this was a post-renal transplant patient who had this classical presentation of progressive outer retinal necrosis in the right eye. And he was already on azathioprine and prednisolone in maintenance doses. So we, because he was a post-renal transplant, his serum creatinine was 3.1. So in discussion with our nephrologist, he was administered tablet valaciclovir 750 milligram TID as the renal dose adjustment. And because of the Omicron that had just come up in January, he did not come for follow-ups for the intravitreals. However, he continued taking the oral valaciclovir at 750 milligram TID, and he returned at 3 weeks, where the visual acuity improved from 624 to 69, and you can see resolution of all the lesions. So the mean time of resolution of the retinitis lesions is generally 2 to 3 weeks. CMV retinitis, we know intravenous valganciclovir. For new cases of CMV retinitis, oral Valgan is continued in maintenance therapy. Of course, intravitreal ganciclovir injections are routinely given in these patients. We also have intravitreal ganciclovir implants, which can be given in combination. As CMV retinitis is an ocular manifestation of the systemic disease, the antiviral treatment is continued until the immune recovery has occurred, and that I said as CD4 counts being monitored. So to summarize, the body of evidence supporting the current treatment strategies is impressive, no doubt, but there are substantial gaps in evidence base because viral retinal necrosis is not so common where it would allow us to conduct a true randomized prospective clinical trial. The currently treatment regimes are based on individual experiences, limited literature, which is retrospective, and the literature supporting treatment other than antivirals like laser and early vitrectomy is not conclusive right now. So thank you very much.
Thank you very much, Reema, for the very nice presentation. So can we have all the panelists for controversies, please? The first controversy that I would like to discuss is with Bahram. Bahram, this chronic viral uveitis, and we have seen beautiful publications from you. And you showed one patient with CNV and kind of healed choroiditis. When do you suspect chronic viral uveitis, and how would you go about it? This is not the diagnosis that is commonly made all across.
No, that's true. And this is a great question. You know, I compared with the gas atlas. I went to the gas atlas and I found a picture very similar, which was due to rubella virus infection, congenital rubella virus infection. So I think that in these cases, it's too late anyhow. But usually what I try to do, if I have a patient who is resisting to corticosteroids, who is not doing that well under immunosuppressors, I try always to check if there is no viral infection associated. That's the mainstay. However, I would say that fortunately, these cases are very rare. So in most of the cases, the PCR is negative, and then I switch to another immunosuppressor or a biologic agent. But I think that it's good to have this in mind. The topic with macular edema after acute retinal necrosis is another topic, which is very important because many of us have this type of complication. So that's something very different. But again, even in these cases, I try to see if viral replication is under strict control or not.
Yeah, that was my second question to all of you one by one. Macular edema, I understand, is a problem when it happens post-ARN. Would you be desperate to treat it with steroids? And let's begin with Yolanda. What is your take on using corticosteroids, not for therapy, but otherwise steroids and virus? How comfortable you would be?
Well, in our clinic, we usually start with antiviral therapy prior to administering corticosteroids. So I'm not in favor of starting with corticosteroids before proper antiviral therapy is instigated.
Now, suppose the antiviral therapy has been given, the disease is inactive, and the patient now just has macular edema. There is no active retinitis. Would you be tempted to treat that macular edema with steroid?
I would like to give this question to someone else because I'm not an expert on therapy of macular edema. Sorry.
Yes, Mark.
Yes, if we don't have any retinitis, we've treated for a sufficient period of time, I think I would use steroids to try and control the edema. I might start by using non-steroidals and see if it might work. But in this setting, I think steroids can be useful. I would not use a long-term steroids like Osrodex because we do know that you could have some recurrences, but I would not be against the idea of maybe trying first oral steroids in this case so that we get some idea of the level of response if topicals are not effective.
So, Bahram, you mentioned beautifully about interferon and intravitreal. Have you tried intravitreal injections of interferon for macular edema post-ARN?
Unfortunately not, but Vishali, looking at the literature, I have seen many great papers in the Indian Journal very recently. So it's mostly on diabetes, but I think that you can also check that. That's I found this literature very interesting.
Yeah, I tried in one patient and it worked for some time, but nothing too great.
The problem we have at this time, Vishali, is that interferon alpha, as we had before, is no more available. So we have only the pegylated form. which to me is not the same, but still we can use it in some selected cases.
Now, there is a very interesting question from Sonia. I think she's from Tunisia. She says you are now recommending multiple antiviral intravitreal injections. Is there a risk of retinal toxicity? Anirudh, would you like to take it?
So usually with the dose that we use, I think with a weekly dose of intravitreal, I think the toxicity concerns are not so much. So we often add the intravitreal therapies to our patients. And so far, we haven't seen patients with toxicity because of antiviral agents themselves. So they appear to be quite safe.
Okay. And Rima, you talked about therapy, and there were multiple questions following Bahram's talk. Would you titrate your therapy based on your PCR results, like Bahram showed us twice the 8 type of virus, which could cause necrotizing or even non-necrotizing retinitis? Now, suppose you get your PCR result, simplex, or zoster. Let's not get into CMV at the moment. Would you change your therapy, duration of therapy? Simplex versus zoster, let's stick to that.
For retinal necrosis, simplex versus zoster, no. But they've recommended that some people should prefer to have val-acyclovir for VZV or in a higher dose. So val-acyclovir has been recommended maybe to start as 1 gram TID induction dose. You can go up to 2 grams. So some reports mention that if it is VZV, you can go to 2 gram TID, but then at the discretion of this. So personally, I would not change for on whether it's due to because of herpes simplex or VZV. And second question is PCR titration? No.
That's the same as PCR, yeah.
No.
So John, you would be seeing a lot of HIV patient, I assume.
Not so many actually, but in the past, yes.
Okay. So do you give them long-term antiviral therapy indefinitely?
Well, we don't have very good treatment in Ethiopia for any of these conditions, just oral acyclovir. So I think giving treatment if the patient has something to save, could be a good idea, especially if the lesion was close. But I don't really know how you know the answer to the question. On the other hand, here, most of the patients aren't really willing to pay that much money, for long term. So it sort of becomes a theoretical issue.
And there is a question from Ashraf Avaja. Sometimes we are going to give prophylactic antiviral for long term, especially if it is associated with encephalitis. I personally had 2 patients who had encephalitis in the past, and following COVID infection, they ended up with ARN, which was managed, but I had to ask my neurologist that do they need a long-term prophylaxis? And they said no, so I still gave for 3 months, but I also do not have the answer. So Mark, Bahram, Anirudh, Yolanda, Rima, anyone has the answer, would be happy. Yeah, Anirudh.
So I think it's only the ophthalmologists we persist with long-term therapy, but if you talk to neurologists or even infectious disease, they are never in favor of a very long-term therapy.
I agree. So
yeah, but it's not for this reason that they are always right.
Yeah.
No, that's true. I just like to add that intravitreal methotrexate is an option in persistent macular edema. If the virus has healed, I think methotrexate works very well, and probably I'll use methotrexate more often than Ozurdex.
How often you inject?
One report of, I didn't find any report of ranibizumab, but I found one report of aflibercept for CME post-AN.
But one thing that you were asking before was about, I think it was related to immune recovery. So obviously with the cytomegalovirus retinitis, it's very well characterized. And so if you have a rise in the CD4 count, you could feel quite comfortable stopping the treatment. I think for the other conditions, like maybe for progressive outer retinal necrosis, maybe you would feel comfortable with that if you're fortunate enough to have any vision left. But the acute retinal necrosis, it can happen, in in people with that are immunocompetent. And so I don't really know how to answer that question. As
They've
far as
given
the
Pseudophobia as a long-time maintenance in HIV positive patients.
what's that?
Pseudophobia has been given as.
Yeah, they have. That's before we had immune recovery. I think, going on from what John said, if you're able to get rid of the virus and you have a CD4 count that rises, there is other evidence experimentally that shows also that it's only after 6 months to 9 months that you have a fairly good immunity against different types of pathogens. And so I would continue certainly with antivirals in this population until we have a loss of viremia, until the CD4 started to recover, and probably continue the treatment for 9 to 12 months at a minimum.
So Mark, now that you are on it, Rima showed a patient of post-renal transplant who would, of course, require to be continued on immunosuppression. So how long are you going to give antiviral for these patients?
Well, let me answer the question differently. If we look at our friends that are anterior segment surgeons and they deal with the herpetic, keratitis, there are patients that stay on chronically for years simply because it's the only way to be able to control. I think part of the answer to this is how close are we to the macula? And if we were to run a risk that the reoccurrence would lead to loss of vital function in terms of vision, then I would probably keep the patient on a low dose indefinitely. You have to check their liver functions on a regular basis, but on the other hand, it's not a very toxic combination of it's not a very toxic medication, so why not? Particularly in the setting you're describing. Somebody who needs immunosuppression and is going to have low T cells probably for the rest of their life.
I think that you are absolutely right. And the fact that the cornea specialists are using it for years, if we are dealing with retinal necrosis, then we have to do the same and even more. So to me, there is one main issue is that if you have a very localized retinal necrosis, then of course you can discontinue and monitor the patient. But if you have a one-eye patient, you have most of the retina which has been involved, then you don't want to stop, as it's the case with toxoplasmosis and Bactrim prophylaxis. It's the same.
Now, there is a question related to that. It's from Peach or Pong. He says that, could you give the zoster vaccine to prevent the recurrences? It's the same at the contralateral eye to prevent retinitis?
I don't think so.
No evidence.
No evidence. Okay, Anirudh, this is going to be the last part of discussion. You showed very interesting concept that you see the lesions on OCT, and if you are seeing those cystic kind of a lesion, these are the patients who are going to develop detachment, and you suggested prophylactic vitrectomy. So I would,
I just stop short of saying that, but I think these are patients who probably are more predisposed to develop retinal breaks. So I think over time, with 25 gauge vitrectomy coming in, I think it's become safer to do vitrectomy in these eyes. So probably if we take out these patients, and this could be a separate project actually, if you take out these patients of OCTs who have this cavernous pattern, and maybe these are the ones who are more likely to develop detachments. So probably there could be a role of prophylactic vitrectomies or even laser for these patients compared to other ones.
But, we all understand as surgeon that vitrectomies in arm 27G even, you get stuck with the hyaloid and the mid-periphery because it just doesn't separate. So regarding the prophylactic vitrectomies are laser. Now, there are a lot of questions related to laser. All of you one by one. Rima, do you think there is any role of prophylactic vitrectomy or laser?
No.
Mark?
I'll answer both questions. So with laser, it's okay if you're able to get in there. And very often patients present without having much vitritis. If you can get laser in on 5 to 6 rows, please do, because it may be helpful. With prophylactic vitrectomy, I'd consider it if a person has at least 2 clock hours of involvement. If it's only one or less than two, it's not really necessary. The risk of having a detachment is low. And I think there with good antivirals, you'll do okay.
Okay, perfect. And Bahram, Sonia is asking again, is macular edema frequent in diabetic elderly patient with ARN with no diabetic retinopathy? And for the treatment, is there any role of periocular injection of steroids or valcyclovir? I personally haven't seen this situation.
I have not seen, maybe diabetes is protecting against ARN because I haven't seen a patient with diabetes and ARN. Maybe not, you don't have both big diseases together. But I would say this is for this one. And for periocular injection, again, if viral replication is under control, I prefer maybe doing a periocular injection than intravitreal injection. But anyhow, this is a discussion.
And you showed those pictures of neonatal CMV retinitis. So there is a question for you. Is there a screening protocol?
Well, if you have CMV, if you have AIDS, and if you have immunosuppression, there is not a screening, but usually we wait for complaint of the patient, except if you are below 50 CD4 per milliliter. And then in these cases, it's good to check every 2 or 3 months to see if there is no viral retinitis, CMV retinitis.
For neonates.
Oh, for neonates. Yeah, for neonates, usually we have to check. Yeah, it's a protocol. It's at birth, and then I think it's like toxo, kind of. At the beginning, it's even more often than toxo.
Well, with this, I would like to thank you all for being there and being with us, Saturday evenings, which is not our mornings for some of you, which is not easy. And I'm really thankful to all our friends who join us month after month. The next one will be on 7th of January and on VKH. I'm sorry, last time I said VKH, but that's the following one. So this time I rechecked it again. It's VKH on 7th of January. So we look forward to your inputs. And as Mark said, John Campan and Rima are going to decide about the exciting case discussion following our webinars are over. So please write your input and suggestions as to how you would like us to proceed. With this, thank you, Anirudh, Halenda, Mark, John, Bahram, and Rima. Thank you very much.
Thank you. Thank you.
Thanks.
Take care.
Thank you. Have a great weekend.
Thank
Bye.
you. Bye-bye.
Bye-bye.
Bye. It may not be used therapeutically, but administering. There is a new vaccine, Shingrix, which is a subunit vaccine, and it is shown to be very effective in the elderly population to prevent reactivation. So shingles. So it might also prevent reactivation causing ARN. So.
Okay, that's
Yeah.
you. It doesn't do any harm.
No, I think it would be a great idea to get the vaccine.
Yes.
Yeah.
Okay, with that.
Okay. Well, thank you, Vishali, again, and Rima. And
Thank
hope
you.
to see you next time.
Yeah.
Bye-bye.
Bye.